Thank you, sir, for giving me this opportunity. I am giving you the brief outline of management of suppurative keratitis. Only outline. The details will be done by subsequent speaker. I do not have any financial interest in any of the presentation. In spite of best medical management, we know that 15 to 35% of all infective ulcers do not heal. They need surgical interventions. It may vary from repetitive surgical debridement to therapeutic penetrating keratoplasty, depending upon the extent and severity of the ulcer. The indication for surgical treatment are large ulcer with risk of scleral involvement or perforation, extreme thinning or desmetocele, frank perforation, worsening in spite of appropriate antimicrobial therapy, which we call non-healing corneal ulcers, and uncertain etiology with worsening on medical therapy. The options are repeated debridement for better penetration, especially in fungal keratitis, tissue adhesive with bandage contact lens, lamellar or full thickness patch graft, lamellar or full thickness penetrating keratoplasty, conjunctival graft, either sliding or thin flap, tarsorrhaphy, amniotic membrane application like multi-layer amniotic membrane, sandwich technique, etc. First, coming to the intracameral injection, especially for proven fungal ulcer, indication ulcer not responsive to medical therapy, thick hypopyon may be more than 1/3 hypopyon, endothelial exudates are more with healed surface. The recommended antifungals are amphotericin B 5 to 7.5 microgram per 0.1 ml or voriconazole 50 microgram per 0.1 ml. Intrastromal amphotericin B or voriconazole also being tried by many authors recently. These are the typical example of a non-healing ulcer. So an amphotericin B was given 7.5 microgram after 5 days, and then after 7 days his ulcer healed completely. Sometimes we see this kind of candida ulcer. You see the huge endothelial exudate, and after given intracameral and intrastromal Ampho B, this ulcer responded nicely, and both are given at 5. Sometimes you have to repeat the injection 2 or thrice depending upon the response of the patient. Tissue adhesive with BCL, like it is indicated for small perforation 2 mm in size, persistent corneal fistula, and before procedure the bed should be dry and free from epithelial cells. Adequate time should be given for complete drying of the adhesives. Tissue adhesives normally use a cyanoacrylate glue, and usually 2 to 6 weeks are required for complete healing. Sometimes you need to remove the BCL on every 3 weeks or 4 weekly, and sometime in cases you remove the BCL, remove the glue carefully, otherwise there might be chance of recurrent perforation. These are the few cases. Like this one case with you see that saddle was positive small perforation, and this patient was given glue with BCL. Therapeutic patch graft indication is large desmetocele or pseudocornea, perforation more than 3 mm, very effective in tunnel abscess, especially in FECO or SICS. Patch graft is usually 4 to 6 mm in size, lamellar or full thickness both can be used. Interrupted suture, sometimes it may be reinforced because sometimes the patch graft are so small we cannot give adequate very good sutures because most of the time the dissection is freehand dissection, so you may add glue to it and put a BCL over. We call it tissue plus glue plus BCL. Tunnel abscess is a big thing and very difficult to treat them medically. So if you get a chance to do a patch graft, sclerocorneal patch graft, maybe full thickness or partial depending upon the involvement of the posterior layer of the incision, and it gives gratifying results. This is one of the case where therapeutic patch graft and then combined with vitreoretinal surgery, and the postoperative outcome was good at the end of 14 days. Therapeutic keratoplasty is another, full thickness therapeutic keratoplasty, because you are removing the total pathology as a diagnostic technique to form a good source for histopathological and microbiological examination, because sometimes we may not be able to culture the microbial agents even after repeated attempt. So this is the time where you can have histopathological examination, and it maintains the integrity of the eye for future optical graft. If done properly with good optical quality tissue, 40 to 50% of this patient recover useful vision, carries better prognosis in bacterial corneal ulcer. A recurrent graft infection though occur, it might be between 10 to 25% of all therapeutic PK. She is a microbiologist, a PhD microbiologist, a scientist. She developed this ulcer, and we had only this cornea, a smaller cornea in hand, and the patient is doing well even after 6-9. And this patient came from Bangladesh. This patient had a DALK procedure for keratoconus, then it had infection. Then we know that in Bangladesh they try always this conjunctival graft. The conjunctival graft was done over and above that infected graft. And when we see this patient, this was the picture, and we emergently we operate this patient from limbus to limbus with a good optical quality tissue. And you see the picture, the same patient after 1 year. The patient is following up with you. She is now in BSc standard, just 21 or 22 years old. So if you attempt rightly, some of the cases may be good. Sometimes we do peripheral full thickness patch graft. Tarsorrhaphy is the very important measure. Sometimes we do not have tissue in our hand, but many a time if you do tarsorrhaphy, you can save a lot of the eye, and sometimes you may see surprisingly the ulcer healed with a retention of good amount of vision, especially with perforation of the corneal ulcer. So you may decide whether you go lateral or paramedian depending upon the extent of perforation and where is the site of perforation, and this could save a lot of eyes. Conjunctival flap is indicated in certain cases. We are not doing much here, but as I said, and I got some photograph from Bangladesh, but these are some of the procedures which gives good things. And you see, this is from my friend Bangladesh. He is practicing in Dhaka, and he is a very good corneal surgeon, but unfortunately they do not get cornea in Bangladesh, so they have to sometimes do this kind of conjunctival graft, and you could easily understand from figure 1 to figure 4, this is a tremendous job they have done. Similarly, this is another case, so perforated corneal ulcer. So this way, if you do not have any tissue in hand, you can do, there are different types of sliding conjunctival graft. So in summary and conclusion, in spite of best medical management, we know that 15 to 30 or 35% of all infective consults do not heal. They need surgical intervention, planned or on emergency basis. The available options are encouraging. Intracameral injection, either Ampho B or voricalogen, has some value. A good eye bank support is the key to success of surgical management. Even a good tarsorrhaphy can save the eyes. Thank you very much, and take challenges.